Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. In practice, I noticed that many doctors request a lot of hormones before starting induction ovulation. Some of these hormones are unneeded and some are requested in a wrong time. And actually, the interpretation of these hormones and the impact of requesting these hormones on the treatment is vague for some of us. So I'd like to summarize some important issues regarding hormone request for an infertile patient before induction of ovulation. I would like to address the first point that if you have a hormonal request, you should know the method of estimation of the hormones in this particular lab. Is it done by ELISA, automated immune assay, ECL immune assay, or even urinary values for some hormones like LH or so? So the identification of the method of estimation is very important because you cannot diagnose the disease or compare the results of different labs done by different methods of estimation. And some of them are more accurate than the others. This is number one. Number two, you should know that there are some lab variations in the results, and every lab has its schedule and its normal range. So we don't have to compare results of different labs. And it's better to know the standardization of the results to have a definite diagnosis and go through the treatment of this case. We can summarize fertility hormones requested for infertile patients into two groups. The hormones that are requested one time during the course of induction ovulation or during the course of assisted reproduction, and repeated hormones. So you have to categorize them in your mind that some hormones I'll request for some time only that mainly are hormones of the ovarian reserve, which are AMH and FSH. Also, TSH and prolactin may be requested in some cases or in most of cases of infertility, particularly those subjected to ART. And HCG is requested on the day of ovum pickup if you suspect that the patient has empty follicle syndrome or liable to have it. On the other hand, some hormones are requested frequently during the course. So if you are talking from scientific and economic views, you should categorize the hormones requested as one-time hormones and repeated hormones. And these repeated hormones are actually the triad of LH, estradiol, and progesterone. We start by AMH. Of course, it is one of the best biochemical tests of the ovarian reserve. It is not affected by the phase of the menstruation, so it can be requested at any time. And actually, it is requested once. Don't request it too much for your patient to save her money, and it does not add too much for her. But as we know that it is just one of the tests of ovarian reserve, as it is one of the biochemical category which includes other hormones like FSH, FSH-LH ratio, and HB. But there are some other categories of the ovarian reserve testing, including biological tests, which is the most important chronologic age of the patient. Also biophysical, which is ultrasound detection of the antral follicle count and of the both ovaries. And sometimes when you are doing a laparoscopy for the patient, you can take a biopsy of the ovary to see if she has follicles or not. So we have different categories of ovarian reserve testing. Don't rely on one test as a test of ovarian reserve. It is just one test which is suggestive of ovarian reserve status. And more details on the ovarian reserve are present on this channel in different videos, like understanding poor ovarian reserve or a simplified approach to understand poor responders. As I told you, it is a single biochemical test of ovarian reserve. If it is 1 or more, this is good. If it is from 0.5 to 1, this is intermediate. And if it is less than 0.5 nanogram per milli, this means that poor ovarian reserve is suspected. We cannot guarantee that this case has poor ovarian reserve on a single test. And FSH also can be used with AMH as in combination to check the ovarian reserve status in addition to antral follicle count. Another important issue is that we use the antral follicle anti-mullerian hormone test as a biochemical in addition to biophysical, which is antral follicle count, and biological test, which is age, in one equation, which is ovarian reserve reduction index, which is multiplication of AMH and antral follicle count and divided by the woman's age. And by this way, we can predict the ovarian reserve using 3 methods of estimation. And if it is less than 0.5, this means that the patient would have poor response to treatment, and if it is 0.5 to 0.9, optimal response to treatment, and if it is more than 0.9, this means that the patient may have hyper response to treatment, as mentioned by some publications. The second one-time hormone is FSH, and FSH, you know that at the beginning of menstrual cycle, it shows a little bit lower level, but increases with time. So the best time of estimation of the basic FSH is day 2 to day 3. And if you measure FSH late at pre-ovulatory or late of the menstrual cycle, the measurements of the FSH are not indicative of the ovarian reserve of the patient. And it is done once. Don't request FSH too frequent. And if it is less than 10, this is good. If it is between 10 and 15, this is borderline. If it is more than 15, this is a bad test. But FSH more than 10 predicts poor response to ovarian stimulation. If it is more than 18, this predicts a poor pregnancy outcome, as mentioned in some publications. So poor ovarian reserve is increased FSH more than 15, as I told you, in a regularly cycling female. This is a good predictor of the poor response. Again, it cannot be alone as a good test for ovarian reserve. We use it in combination with other tests. And here we can use it with estradiol. So the estradiol, also basic estradiol cycle day 2 to 4, in addition to FSH, if the estradiol is less than 80 picogram per milli and FSH is less than 10 milli international unit per milli, this is suggestive of good response of this cycle. So FSH in combination with estradiol suggesting optimal ovarian reserve of this patient. Again, this slide is important because it uses combination of FSH, anti-mullerian hormone, and antral follicle count. If the FSH is less than 8 or 10, anti-mullerian hormone more than 1, antral follicle count, both ovaries more than 8, this is the best or optimal reserve of the ovaries. Another test that is requested once during your cycle of induction is prolactin. And prolactin usually normal from 2 to 20. The mean is 14.3. The highest mean of day 8 and day 14 with second peak of estradiol. And some studies suggested that persistent hyperprolactinemia, particularly if confirmed by two samples, may lead to luteal insufficiency in cycling women or recurrent miscarriage. And actually, this suggestion during ART is not highly confirmed in some studies, and the impact of the hyperprolactinemia is unclear, and future evidence-based studies are needed to determine whether normalizing prolactin can improve ART or not, and this is a recent publication. Another important that is requested basically before starting induction ovulation is TSH, and TSH has a fixed value of 4 milli-international unit per liter, and we have to request TSH and thyroid antibodies for all ladies, particularly those with medical history suggestive of thyroid dysfunction like weight change, fatigue, irritability, palpitation, and menstrual disturbances. So the history and physical examination of thyroid are important. And we request TSH and thyroid antibodies. Don't request T3 and T4. And according to the request, you can divide the patient. Has TSH more than 4? So this is suggestive of hypothyroidism, and you have to start levothyroxine for 6 weeks prior to ovulation stimulation or ART, and follow up thyroid functions every 4 weeks. But if the TSH is less than 0.3 milli-international unit per liter, this means that the patient may have hyperthyroidism, and you have to request at that time T3 and T4. If they are normal, check TSH after ovulation induction. And if the T3 and T4 are increased, so this is a case of hyperthyroidism, and you have to treat these patients or to do surgery if required. Now, the area between 4 and 0.3 is intermediate. And in such a case, you have to order for to check the antibodies already requested for this patient. If they are normal, so the patient has normal antibodies, normal TSH, so she is suitable for assisted reproduction or induction ovulation. But if the antibodies are positive, you have to follow up thyroid functions every 4 weeks, and you can start treatment whenever the patient has history, has evidence of hyperthyroidism by thyroxine, by antithyroid treatment. The last hormone that may be requested during induction ovulation for one time is beta-HCG, and this hormone is requested in some cases that you suspect she is liable to have empty follicle syndrome based on previous history and based on the findings as shown in my previous presentation on empty follicle syndrome. And this is essential in cases of iatrogenic malgenian empty follicle syndrome, and the HCG is requested on the day of ovum pickup. If it is positive or 40 milli-international units per milli or more, this is suggestive that you can find eggs when you make aspiration of the follicles. Now we go to another type of hormones, which is the variable triad of LH, estradiol, and progesterone. And this triad is frequent accompanying tests during the course of induction ovulation. Don't forget this triad. Every time your patient comes to you, you should request these 3 hormones because they are very essential for monitoring the success of your induction ovulation. And of course, LH increases in pre-ovulatory, and in the basic time, it should be low in the day 2 or day 3. So if LH is measured at the beginning of menstrual cycle, day 2, day 3. It should be correlated to FSH, as I told you, as a biochemical test of ovarian reserve. In addition, if it is very low, this means that we have to add LH to FSH for induction ovulation. And also, if it is very low, and it can predict GnRH agonist triggering failure in long protocol. It should be 0.5 to 2.5 unit per liter. If it is less than this, this may predict failure of the triggering of this protocol. Of course, LH has different values in different parts of the cycle, and this comes in another lecture. Today, I focus on the starting point of the menstrual cycle or the induction cycle. So we can add LH to FSH in some cases if it is very low in the patient, if the patient has poor ovarian reserve, old age between 35 to 40, if we are using antagonist protocol in 25% of cases. Some of these cases are associated with increased LH during first 5 days, and this may predispose to a sharp LH drop following first antagonist dose. So we can add LH for this group of patients. And these are the collected the indications of adding LH from different literature to highlight the importance of estimation of LH at the beginning of the menstrual cycle. In long protocol for IVF, IGSI, don't forget number 5, which is day 2, LH should be less than 0.5 units. Estradiol should be less than 50 picogram, and endometrium should be less than 5 millimeter. If these 3 criteria are found, you can start induction of ovulation. What about estradiol? Estradiol in the beginning of menstrual cycle, it is very low and it has 2 peaks, and pre-ovulatory increases in the first peak. And importantly to know that estradiol is used with FSH, as told previously, for estimation of the baseline ovarian reserve and combination. FSH should be less than 10, estradiol should be less than 60. So this is optimal for induction ovulation. Also, estradiol is used for monitoring the case of controlled ovarian hyperstimulation, low risk of ovarian hyperstimulation with estradiol if it is less than 1,500 to 3,000 picogram. So these are the uses of estradiol at the beginning of menstrual cycle. Of course, estradiol is correlated with the follicle diameter and number. So estradiol is measured on day 3 with FSH to detect ovarian reserve as optimal ovarian reserve or not. Also, estimation of estradiol at the beginning can predict the clinical pregnancy rate. If it is between 30 to 50 picogram per milliliter, this would suggest high pregnancy rate. Also, the level of estradiol at the beginning of menstrual cycle can suggest the amount of gonadotrophins used for induction ovulation and the duration of stimulation. But if it is more than 60, you have to stop, because this may be associated with lower pregnancy rate. And if it is more than 80, you have to counsel the patient for cancellation, because 80% of these cycles would be associated with non-structural ovarian cysts or persistent luteal function cysts with derangements of the early follicular phase. So you can go up to 50. This is good. From 20 or 30 to 50 is good. More than 60, you have to suspect lower pregnancy rate, and more than 80, you have to consider cancellation of the cycle. In this figure, I tried to summarize to you the importance of estradiol. So day 2, day 3, less than 50 picograms, this is good. And if it is between 60 and 80, this is associated with decreased pregnancy rate. More than 80 consider cancellation. And day 5 should be 300 picogram per milli. If it is less than 300, this means that the patient is slow responder. More than 300, this means that she is fast responder. And at day 8, again, you repeat estradiol. So this test is repeated. Day 8, more than 300, this is good. If it is less than 300, this is non-responsive to induction, and you have to counsel the couple for cancellation. And if day 8 less than day 8 more than 300 and day 5 less than 300, this means that she is slow responder. And at the day of trigger, it should be measured because it should be between 800 and 1,500. If it is less than 800, the patient is low responder. And if it is more than 1,500, this means that she is high responder with a high possibility of ovarian hyperstimulation syndrome. And this for induction of ovulation cycles. But for patients with frozen embryo transfer cycles, we don't have induction of ovulation. So we do day 2, day 3 estradiol. Also, again, if it is less than 50 and endometrial thickness less than 5, this is a good start. And you can start by estradiol 6 milligram daily and for 10 to 12 days, and then do transvaginal sonography if the endometrium became 9 or more and the no follicles, no cysts. So after you start progesterone and daily progesterone, on the 4th day of daily progesterone, you estimate estradiol. Again, if it is 200 or more, started by 50 at the beginning and now 200 or more, this is good. If it is less than 200, you have to add estradiol at that time. And again, progesterone should start by 0.5. Now it should be 15 nanogram per milli. If it is less than this, you can add progesterone at that time. And the 4th day, day 5 of progesterone, until you have good endometrium for embryo transfer. The last of the triad of these hormones is progesterone, and progesterone has different values in the menstrual cycle, but at the beginning, again, it should be 0.1 to 0.7 nanogram, and pre-ovulatory increases, and after ovulation, of course, it increases. And the SRM consider more than 3 nanograms suggestive ovulation, but optimal or ideally at day 21, it should be 10 or more. So estimation of this hormone in different timing of the menstrual cycle is essential to estimate the level of progesterone and the success of your treatment. One of the important issues is pre-ovulatory progesterone estimation. If it is more than 1.5 or 1.7, you consider freeze-all technique because it leads to premature luteinization and is associated with low pregnancy rate. And in this sheet, I try to summarize to you the important issues essential for induction ovulation, testing of the baseline hormones by FSH, LH, antimullary hormone, prolactin, and thyroid, TSH. These are very important in the beginning, and recommendations now TSH with antibodies, all in addition to endometrial thickness. And you have to collaborate the findings of ovarian reserve, testing of FSH, and intrafollicular counts, and antimullary hormone. The second important issue is ovarian response prediction index, which is using biochemical, biophysical testing and biological testing. Last point in this sheet is the use of day 5 and day 8 estradiol for estimation of the success of the induction ovulation, and importantly, to collaborate these findings to define the starting dose of gonadotropins. If the intrafollicular count is less than 7, the antimullary hormone is less than 1, the baseline FSH is high, So this means that the patient is a low responder, and you can start by 5 ampoules daily, 375 international daily. But if the patient has high antifollicular count, more than 14, good anti-hormone than 3.5, and FSH is less than 10, you can start by 2 ampoules daily because she is liable to be a good responder. And in between, you can use about 3 ampoules in the cycle. By this way, you got an idea about your patient before starting induction regarding the doses, the frequency, and frequency of testing. More details will be shared with you in a detailed lecture on the role of hormones for ovulation induction in coming lecture soon. Thank you very much.